So thank you, Andreas. I leave it to you now, and see you all later. Thank you.
Firstly, I'd like to thank our previous speakers and Rhea for moderating our fantastic first session. Now I'm happy to move us to our next session, the frontline of climate smart solutions. For those joining us right now, my name is Andreas Ekvall. I'm a Senior Climate Officer at Healthcare Without Harm, and I'll be moderating this session. Today we are fortunate to have 3 experts with us, each on the front line of climate smart solutions. We will hear from institutions like the Karolinska University Hospital, Hampshire Hospitals NHS and Newcastle NHS, who are implementing cutting-edge practices to quantify and reduce emissions. But before we dive into this session, a reminder that any questions will be addressed during the Q&A portion of the session, which will take place after the panelists have presented. Feel free to submit your questions in the chat. We will address all questions that time allows. But let me begin by discussing a few challenges related to estimating and reducing the emissions from healthcare. The road to reducing the emissions from the supply chains is not easy. Healthcare systems have long operated in a linear economy: produce, use, and dispose. The very tools used to care for patients are contributing to climate change. This is a call for action and for a transition to a net zero health sector. However, integrating carbon management in healthcare planning, especially in the supply chain, is complicated. One of the biggest challenges is data management. The healthcare sector relies on hundreds, if not thousands, of suppliers with thousands, if not millions of products. Taking meaningful actions requires us to understand the emissions from suppliers and products. This makes calculating and managing these emissions a daunting task. It further requires us to influence and engage with suppliers to find efficient and innovative solutions. But we also need to encourage suppliers to not only track their emissions, but to actively reducing them. Reducing emissions from services and products also necessitates new and more efficient medical practices while meeting the needs of patients. But as we will see, these challenges are not insurmountable. Today, we are joined by healthcare providers tackling these challenges by reimagining healthcare, collaborating with suppliers, developing new tools, and finding new climate smart solutions. The speakers are forerunners. Now I'd like to welcome our first speaker. We're honored to have Kanko Müller from the Karolinska University Hospital in Stockholm, Sweden with us, who will share experiences of calculating and reducing emissions from medical equipment and supplies. Kanko, you're welcome to the stage.
Thank you very much.
We can also see your presentation, so please go ahead.
Perfect. Thank you. First of all, I'm honored to be here, so thank you very much for the opportunity to talk a little bit. So my name is Kanku. I'm a climate and sustainability analyst at Karolinska University Hospital, and we'll speak a little bit about how we try to reduce emissions from medical equipment and supplies with our climate smart solutions. So a little introduction, first of all, who we are. We are one of the largest university hospitals in Sweden, providing specialized and highly specialized healthcare for adults and children. So we have around 1.3 million patients per year and 1,180 hospital beds, with employee numbers around 15,000. So quite a big institution, and therefore also a lot of challenges when it comes to sustainability. We are part of the region Stockholm, so I've heard Caroline Pettersson talk earlier about the region and the healthcare sector in that. So we are one of the biggest healthcare providers within that region. And we are owned by the regional council, which means that we also get our budget from them. But with the budget also comes some responsibilities. So the Stockholm region has some sustainability requirements for us. such as that we have to use an environmental management system. We need to reduce the usage of environmental damaging pharmaceuticals. We need to reduce carbon emissions and increase circular resource management. Also, we should increase the usage of organic food in the patient meals and work with reducing food waste. Apart from that, we also have our own sustainability program, which we have developed to further be sustainable at the hospital and like to bring out the sustainability goals to a ward. We have 7 sustainability goals within the areas of social sustainability, environmental sustainability, and sustainable economy. Today, I will focus on the environmental sustainability part of our sustainability program, with the 2 goals that we should reduce our emissions from chemicals and pharmaceuticals, plus also increase the circular resource management and lower our climate impact by 40% by 2027. And these goals are, of course, also targeted towards the goals that the region Stockholm has. So we want to, of course, contribute to reaching the goal of being climate neutral by 2035. So this corresponds very much to what you've seen already by Caroline earlier. So this shows that the emissions in the region Stockholm, scope 1, 2, and 3, and that the healthcare and medical care sector is one of the biggest emitters in the region in the scope 3 area, while the emissions from scope 1 and 2 are compared to our scope 3 emissions very, very small. Therefore, we see the importance of tackling emissions from purchased goods, materials and services, product use, and all the other things that fall within scope 3. But how do we do that at Karolinska? So our strategy is to give departments and wards the tools to improve and take responsibility for their own sustainability, because we are a team of 6 sustainability analysts and strategists here at Karolinska, with 15,000 other people working at the hospital. There's of course a huge challenge to get all the sustainability work out and get out the goals and the work we want to do. So we are working with the goals that I presented earlier, and to them we have coupled sustainability activities. So for example, when it comes to those environmental goals, we tell wards, okay, one of the activities you could choose for this year is to work with throwing away less of your medical equipment or medicals, or try to change from one-time use products to more sustainable long-term use products. So we want to steer them in the right direction, but give them enough room to make the decisions themselves, so they really own their work and feel proud of it and feel like they really make a change themselves. The other way, which I'm going to present a bit more thoroughly, is that we're using a business intelligence tool, which enables visual analysis and interactive monitoring across all organizational levels. How does it look like? So this is only a short example overview. I'll go into more details very shortly. So this is one of the dashboards we can create, which shows the environmental aspects of the hospital. So you can see on the right-hand side, filter function. So here, everybody working at the hospital could, in theory, go in. If let's say I'm a doctor at the cancer ward, and I want to see, okay, how are we doing when it comes to prescription drugs, and also when it comes to traveling or emissions from specific single-use items. Then I go in here, and I can choose my operation and the section, and can go down to the cost center, so the lowest, or the highest filter view at the hospital, and see exactly how's it going for me, how's it going for us, do I see any problems, and maybe also compare myself. Okay, we're Cancer Ward 1, how's Cancer Ward 2 doing? Are they maybe a lot better when it comes to emission from single-use items? Well, then maybe we should talk to them and see what they're doing. So it's really give everybody the opportunity to own their own responsibility and sustainability goals. Going into more detail at how we try to work with CO2 emissions from scope 3. So here's an example of how we are working with emissions from some selected single-use items. These are some of the items where we saw they have the biggest emissions throughout hospital, and of course also some of the items we actually have the emission data, because that's also how a lot of predecessors have now already told. The problem is that we don't have all the scope 3 data. We don't get them from through procurement, or it's some kind of secrecies that the company don't want to give out. But for these things, we have them, and also the Stockholm region is working with procurement of, in the future, getting some more of those Scope 3 data. But so here we see that examination gloves and aprons, so the single-use ones, are some of the highest emitters at a hospital. And while our emissions over time are showing a little bit of a downward trend, it's definitely visible that we need to work a little bit more in that area. The good thing with this tool is also when you go hover over it, it is interactive. And so you could see something like this coming up. So if you look at 2024, when it comes to examination gloves, so far this year, we've already bought around 25 million gloves, which have an emission of 480,000 kilograms of CO2. Just to paint a picture here as a comparison, a Swedish citizen on average has per year an emission of 8,000 kilograms CO2. So just the emissions from our glove use has been the same as the emissions from 60 Swedish citizens this year. Also, aprons have a similar size. We have used a lot less than the gloves, but they have a lot of higher emissions. So also they are around about the same number of Swedish citizens' CO2 emissions that is comparable to. Another way we're trying to work with the measurement of increased use of consumable products is looking at overconsumption, because until 2019 we had done a lot of good progress when it comes to the use of single-use products or those that have very, very high emissions and are very, well, climate unfriendly. But then the pandemic came, a lot of working ways changed, and now that some time has gone, we see that we are still not back at the levels we were at before in a lot of areas. So to give a little example, we are trying to look at, for example, the single-use gloves that we use. If before the pandemic we see, okay, we use about 2 gloves per patient, we might see that now we use 3 gloves per patient. And when that is, we would have 1,000 patients, that would mean that we use 1,000 gloves more than we have used before. And then it comes to speaking to the departments, seeing what has changed. Can we change the way we're working? Maybe be part of some projects. So this comes into the next part where I'm soon going to present you some practical examples how we are working with the data we see. And then here in the graphic you can see the red would be what we use more now, so the things we overconsume. The green would be what we use even less now, so where we see, okay, this one department has probably done a good work on these things. And then we can also go out and talk to them and ask them to give us some examples. Okay, how have you changed your ways of working that you actually are using less of this specific product? And the same then also, of course, goes for money. So the red overconsumption also means that is money we should not need to spend. So it's a very twofold way of like showing that we don't always need investments to be more climate friendly at the hospital. Sometimes it can save us money to just look into the data and try to rework the way we work. So this brings me to the chapter of success stories at the hospital and some practical examples. Mainly we work with procurement, rethinking and adapting the way we work, and some innovation projects. So diving into some examples, we have managed to reduce the food waste from patient servings by over 55% since 2017. And that's mainly through changing the ways we work, the ways patients can order their meals, and then also the change in supply of food. We've also increased the amount of bio-based products. So, for example, the aprons, which are single-use, a lot of them we can also then order as bio-based. So in 2023, 30% of the bio-based aprons were used, and that saved around 207 tons of CO2 emissions. So again, with the Swedish citizen example, that would be around, I think, 30 Swedish citizens, so quite a big number. And we've also are working with increased possibilities for digital healthcare, which reduces the travel times and also leads to increased treatment efficiency. And the last one here is we also reduce the carbon footprint from anesthetics by 20%. So this is, of course, more the direct emissions, not the Scope 3, but still a very, very big step in reducing our emissions in total. So some positive examples that are happening at the hospital are circular aprons. So instead of discarding the single-use aprons after use, these aprons are sent back to the manufacturer. Then they melt them down again to make new aprons out of them. So far, you can see the pictures on the right-hand side. So these are some pictures that were taken at the hospital. One department has tried them out, and they were very happy with them. The nurses and doctors said they have a very good quality, and they don't, there's not a difference visible from the old aprons. And also everybody else was quite happy with them. And if we would implement them at the whole hospital, this would be a possibility to reduce Karolinska's waste by about 200 tons per year. And the carbon emissions from those aprons would then be reduced by around 85%. So very, very big step forwards. So we are now in discussions about that, and we hope this is going to be rolled out very soon. Another project we're working on is the Re-Glove project, which also works with, instead of discarding single-use gloves, they're made more time use and are sent back to the manufacturer for industrial cleaning. And even just being able to reuse gloves one single time would cut our waste by about 100,000 kilograms each year. This is a project that had been started up in Denmark first. We have now implemented that, or we're looking at doing a trial phase at one of our departments. The department is chosen, so now we just need to roll it out. They will test them for a month, and then will come back to us with the feedback. How's it working? How do they think the material is, the quality of the gloves is? How's it working with those gloves? How's it working also with them after they have been cleaned? So this will be very, very interesting to see. And also a very new project here is that when it comes to the medical technical part, we're switching from single-use to reusable medical technical accessories, such as ECG cables or saturation probes. The responsibility for those reusable accessories is carried by the medical technical management through handling the orders and storing the equipment centrally. So that means now, instead of all the different departments ordering the single use by themselves, the medical technical department orders the reusable accessory. They're storing that in a room that is centrally available for everybody, and people from the departments can just go there and take whatever they need. This will come with significant economical as well as emission savings. So we're looking into also doing some calculations about that to get some numbers. And it will also become less vulnerable to any supply disruptions. So yeah, also very, very cool that this came as a project that was not done by us, the sustainability team, but it came as an idea from the department, and they did it all by themselves with some help by us. So we're very proud of the work we do, but we're never completely satisfied, because we want to still get better and come to be emission-free in the near future. So we need to do that by exchanging what we know with other people, like doing this here today. So I really hope you got some inspiration from what I told you about the projects happening at us and how we're working with, especially Scope 3 emissions. And yeah, very happy to get some more insights how other people are working. Thank you very much.
Thank you, Kanko, for shedding light on the emissions from medical supplies and single-use items. It is an emission category that is hard to reduce, but your fantastic examples of success stories shows that it is possible to reduce these emissions and create co-benefits. Next, we will hear from Annalisa Mills from Newcastle NHS. Annalisa will present an innovative method for engaging suppliers in reducing and reporting greenhouse gas emissions. It has been 2 years since their groundbreaking study, so we're excited to hear about the progress made since then. Annalisa, over to you. We can see your screen, so go ahead.
Thank you very much. Hopefully you can hear me okay as well. And thank you for this invitation to share a case study of our approach at Newcastle hospitals when it comes to sustainable and low carbon procurement. If I can just advance the screen, there we go. So before I get into the detail of it, I just wanted to explain, like many people I'm sure on this webinar, I do have many hats. That's not unusual, but just for clarity to explain, I'm part-time sustainability manager at Newcastle Hospitals NHS Foundation Trust. I've been in post for over 4 years and work 3 days a week in that role. However, prior to taking that role, I had set up my own business, which is Smart Carbon Limited, and I still work in that business 1 day a week. I also occasionally lecture at our local Northumbria University and have developed some courses in greenhouse gas accounting and carbon footprint reporting, which are IEMA accredited. My background prior to joining the NHS was working in the private sector, so my entire career has been sustainability. And the project that I'm going to explain to you now is really just something that's really quite common practice in the private sector, and I've just replicated it within Newcastle hospitals. So you may already know a little bit about Newcastle hospitals. Our Associate Director, James Dixon, is on the panel later on today if you want to ask any questions to him. But the hospitals was the first healthcare organisation in the world to declare a climate emergency. And our CEO at the time, Dame Jackie Daniel, made it very clear that the climate crisis was a health emergency. And actually, this is what sparked my interest when I applied for the role and why I wanted to be part of the organisation. So I joined at a time when we were just publishing our climate emergency strategy. Within that strategy, we've got 3 key areas of goals, which is zero carbon care, clean air and zero waste. And underpinning that and the vision that we've stated there is 8 different streams or 8 different work streams within our strategy. I'm going to focus on just the zero carbon care targets for now, which are divided into 2 key targets. We've got one for our footprint, which is a target to measure and report our annual progress towards net zero by 2030. And we've got a target for our footprint plus, which requires supplier engagement if we're to achieve net zero by 2040. We're also the first healthcare organisation to sign up to the UNFCCC Race to Zero. So what you may notice is that our target dates are not aligned with the default dates that apply to all NHS trusts across the UK. The reason for that is we'd already published them and already published the climate emergency strategy before the NHS England net zero plan came out. And so our targets are more ambitious. We're aiming to get to net zero 10 years earlier. And for our footprint plus, including our supply chain, there's a 5-year earlier target there as well. That's because we just feel it's a crisis, it's urgent, and we must act in line with what science requires. But we also aligned our targets with our local authority, Newcastle City Council, and other anchor organisations in the city. So part 1, first thing we had to do was get our own house in order. So that required us to measure and report our performance and track our progress towards that net zero goal. Now that had been done. The organisation had been measuring its carbon footprint since about 2009. So I think 10 years worth of data, all on various Excel spreadsheets. But one of my first tasks was to revisit that calculation and restate what our baseline carbon footprint was. So the approach we took was we used the Greenhouse Gas Protocol, the international standard, best practice standard for carbon accounting and reporting. We did run the calculations through the Smart Carbon platform, but that was at zero cost to Newcastle hospitals because we accessed some funding from the North East Local Enterprise Partnership. And around the time we were working on this, the Greener NHS team published their net zero plan. So we had one eye on that as well to make sure that what we were doing complied with both the Greenhouse Gas Protocol and NHS standard practice. So once we'd done that, the result was we had a new 2019-20 carbon footprint. And what we actually found from the exercise was that year's performance had already been published in our annual report, but by revisiting it, bringing on board the smart carbon consultants, and just through more complete data sets, improved methodology, procedure, etc., we had a 43% uplift in emissions. Now, I'm not talking from one year to the next. I mean a 43% uplift for the same time window. But that, although that might sound like bad news, what that did was give us confidence in our base year that it was complete and accurate. And we can now use that as our benchmark, our base year, to measure our progress against. Now, this table is a bit of a sneak preview, actually. It's from our most recent annual SHINE report, which has just received board approval and will be published shortly. But what you can see is we are making progress in some areas. You can see that we've reduced anaesthetic gas emissions by 61%, for instance, water by 53%, business travel by 20%, waste by 11%, and overall our footprint has dropped by 10%. But our footprint plus has gone up by 93%, partly due to our methodology, which I will explain on the next slides. So how that looks is, excuse me, on the left-hand side is our Newcastle carbon footprint, and you can see that it is falling, but not falling fast enough. The red line is our carbon budget that was developed in partnership with the Tyndall Climate Centre at Manchester University. This is the cumulative carbon emissions that we know we cannot exceed if we're to play any part in capping emissions below 1.5 degrees. You can see we're overshooting it, but we do have a carbon reduction plan which involves a drastic reduction to bring us back under that curve so that the cumulative emissions do not exceed. And you can see the race to zero target there as well. But that really relates to this side of the total impact. The blue part of the pie chart is our supply chain emissions, and that represents over 70% of our footprint, and those emissions are rising. So that's where we turned our attention next, which is our footprint plus. We need supplier engagement. We cannot achieve this alone. We need to work with our suppliers collaboratively towards that 2040 vision. So we started off, as many do, with a very simple spend-based analysis. This gives us a screening estimation of our impact. It's of limited value, maybe worth doing once, but not annually. It doesn't really gain anything to repeat it annually. But essentially, we take the financial spend in pounds. We remove pay spend and anything that could be double counted, like expenditure on energy or waste, for instance. And you can see where the most of our money is going. We then applied the E-class spend code carbon factors to convert money into a nominal representation of tons of carbon. It's of limited value. Some of the pitfalls with this is that the factors themselves are arbitrary, so it's not really measurement. And it suggests our emissions are increasing when we increase spend, and the factors are not updated annually, whereas all other factors are updated annually. But most importantly, that method doesn't capture any real life reduction efforts of any individual suppliers. So it's impossible to track progress towards our target. I always say, if, for instance, you take supplier A and supplier B, let's say for argument's sake, we're buying a similar product from them. Supplier A is your model supplier. They're based locally in Newcastle. They've got renewables on the roof of their factory. They've invested in an electric fleet. Supplier B's product is manufactured elsewhere in the world. They haven't started their decarbonisation journey. Heavy fossil fuel involved in production and transport, yet their product's cheaper. This method would tell me their carbon emissions are lower. So you can see it isn't really that helpful in measuring progress. So we revisited the Greenhouse Gas Protocol, this time the guidance for Scope 3 emissions. And in Chapter 1, it talks about how to measure the carbon impacts from Scope 3 Category 1, which is purchased goods and services. And there's a recognised hierarchy of methods to do this. The bottom of that hierarchy is the spend-based method that we've just looked at. We knew we needed to move up. The top of the hierarchy is supplier-specific life cycle analysis for cradle to gate. Now, we've 3,400 suppliers, each supplying hundreds or thousands of products. they do not all have comparable, consistent life cycle cradle to gate information to provide to us. So we've gone one down from that, which is the hybrid method, which requires asking suppliers to collect their carbon footprint data and feed this to us. So we knew we needed data from suppliers, and we thought, well, they're probably going to need some support with that. So we developed a very simple 5-step process. So that model really is now mandatory for all suppliers. For the first couple of years, it was voluntary. Our Director of Supply Chain and Procurement has now made this a mandatory requirement for all suppliers. We've got about a quarter of our supplier base actively working through it now, with 850 suppliers already working through these steps. So I've got a little bit of information on each step, but firstly, we've asked suppliers to tell us their views in the form of a survey. We asked them what they think of our ambition to reach net zero by 2040. We then signposted them to support. We run an annual webinar or an event, but the rest of it is signposting them to other training courses and, for instance, webinars that might be happening from the Greener NHS team, where we keep our suppliers informed. Step 3 is what's important. We need them to measure and report their performance to us. And then we need them to publish a net zero target and a commitment to reach that by 2040 and publish their own carbon reduction plan. So they're taking ownership for those aspirations. So looking at step 1, you can see, well, it's gone up now, but we've over 850 responses here. We just sent out a blanket email to everybody from our accounting database, which meant that, most of these emails landed with the wrong people. So we were thrilled with the response levels that we got. And what was so interesting, and I was so pleased to see, was the mix of the size of suppliers engaged. 29% of them, nearly 30%, are micro businesses with 10 or less employees. And 25% are small, 25% are medium. So these are the ones that are normally not supported, perhaps, and that we turn a blind eye to. Well, not a blind eye, but we focus a lot of attention on the areas of most spend. Now we've got 20% of engaged companies are from large and very large companies, which is great. But collectively, it's the SMEs that are having the greater impact. So we really wanted to bring them on board. What was also so encouraging was that 99%, were positive, or they weren't sure, but 88% were positive that they support our aspiration to meet net zero by 2040. Those that were not sure or said no, when I clicked into those and read their answers, not one of them was actually saying we don't agree. They had reservations like, we've published a target for 2045 or for 2050. We're not sure if your 2040 aspiration is a bit of a stretch for us, but we're keen to learn. So on the whole, really positive engagement. Step 2 was about us providing some support. So we do have a dedicated supplier webpage. You can all access that from our website. Anybody can copy, borrow, use any of this material. Obviously, we're all in the same battle here, so feel free to borrow and reuse any of it. And really that gives them, access to frequently asked questions and information about the 5 steps. Also in step 2, we run annual events. Fantastic turnouts. We're getting over 100 this is for local suppliers as well. Over 100 local suppliers attending these events. We've just run the second one. First 2 years they were online. The last 2 years they were in person. But at these events, as well as presentations, we offer one-to-one breakout sessions that they can book with a carbon specialist to help them with their footprint. Or they can have one-to-one meetings with the procurement team and have a meet the buyer discussion if they feel they've got something innovative or low carbon in terms of a product or service that they want to tell us about, and obviously lots of networking opportunities as well. We've also just launched a LinkedIn group. Again, all our suppliers are encouraged to join that. It's only just launched. We've got 126 members already, including Dan Shelley there, who's our Director of Supply Chain and Procurement. And this is to encourage the supplier community to talk within that community base, share their challenges, share their solutions. We've also set up a dedicated mailbox so people can contact our Sustainable Procurement Working Group. But probably the most important thing is that has resulted in a real upturn in reported emissions. So in our most recent footprint, most recent annual report, this dark blue here is actual supplier reported data that we're getting now for their scope 1 and scope 2 and downstream scope 3 emissions. So that is a huge upturn in the number of companies. It actually represents 40% of our spend is now with suppliers who are reporting data. 60% of our spend is now calculated here with the hash bit with that old spend-based methodology, and we merge them for that hybrid picture. Now you can see that early indicators are this potentially means our footprint is higher than we thought. But remember, that happened with our footprint plus is potentially higher than we thought. That happened with our footprint when we improved the methodology there. We're not scared of that. I'd rather know where we are so we can track a reduction. And we've got till 2040 to get to net zero. And we're still determined to do that. Step 4 is we simply ask them, have they published a net zero commitment? If so, what year are they aiming to get to that? And they have to provide a hyperlink. So we're measuring percentage of suppliers doing that. And step 5 is a carbon reduction plan. We don't reinvent the wheel. We signpost them to the UK government template for that and to webinars and support to develop that. And again, they need to provide a hyperlink. So this means we can track engagement across steps 1 to 5. And we set ourselves interim targets by 2030 and targets by 2040, all working towards that net zero by 2040 across the entire supplier base, which is currently 3,800 companies. We're on track for all of those targets except for steps 4 and 5, which is suppliers with published net zero targets and carbon reduction plans. So they clearly do need the support. And my final slide there is just what really, really heartens me is the positive feedback that we get from suppliers. I'm not just cherry picking here. It is overwhelmingly positive, either from those attending the webinars, the events, or just taking part in the 5 steps, especially SMEs and micro businesses who are actually saying, you know, thank you for taking a positive stance and supporting us with this. And I really do believe that this is the biggest area of impact, but the biggest opportunity to make a reduction in carbon entering the atmosphere. So we hope it's a very simple model and that more and more suppliers will engage. So yeah, do feel free to reach out if you want any information. I think there's 17 now NHS trusts following a similar approach and many other local authorities as well. And of course, there's overlap within the supplier base, so it's helpful to have those consistent approaches. Thank you very much.
Annalisa, thank you. I've never heard of a healthcare provider who has a platform to engage suppliers. This is an exceptional example of how you can collaborate with suppliers to improve greenhouse gas reporting and get better, more granular data that also is action guiding while reducing emissions. Thank you. Next, we are joined by Hampshire Hospitals, who presented during the previous summit on their groundbreaking work with virtual wards. Today, we are excited to hear about the progress made because the practice of virtual wards could reduce emissions and increase patient well-being. Unfortunately, the team could not be with us today, but let's take a moment to watch this video giving us an update.
Good morning, ladies and gentlemen. My name is David Quentin-Wood. I'm the Clinical Director for Virtual Healthcare for Hampshire Hospital Foundation Trust, that is a medium to large district general hospital based in the southeast of England. I'm also an acute general and colorectal surgeon.
Hi, good morning. My name is Becky Housley. I'm the consultant nurse here at Hampshire Hospitals, overseeing the Virtual Health Hub, working alongside Kate and David to support this work.
Hi everyone, I'm Kate. I'm the Sustainability Specialist working in the South East region under the Greener NHS team. So the South East region covers Hampshire Hospitals.
Great. Well, thanks very much for having us back. Last year, face-to-face in Brussels, we presented to you our preliminary findings when we were looking at whether or not virtual healthcare or acute virtual wards, hospital at home, you may know that as, actually made a difference with regards to carbon footprint. Could this new innovative way of providing healthcare for the sickest patients at home make a difference to carbon footprints? So we've been invited back to give you an update as to what we found when we started looking in more depth at the data we collected at the time. So Kate's going to take us through what we found since then of the last year.
Thank you. So some of you may be familiar with this slide already. This is the NHS's carbon footprint, which was created at around 2019, 2020. So you can see on the screen that we've got a really good understanding of our hotspots, and we're continually working to ensure high quality data is used to track our progress, ensuring that we are meeting any midway targets we've set. In January this year, the NHS annual report published updates on our direct emissions. So in order to stay on track for our midway targets, the trajectory implied a reduction to 5,000 kilotons of CO2e. When calculated, we were at 4,550 kilotons, which is really exciting. We're slightly ahead of targets, although I quickly want to state that this is largely through advances in things like grid decarbonisation and our approach to the easy wins. And we're aware that this is a long road ahead. We also recognise the importance of looking in detail at the patient pathway. So when virtual wards first emerged, it was a bit of a knee-jerk reaction to say that this was a low-carbon model of care and that it would help trusts reduce their carbon footprint. But quite rightly, this thinking was challenged. Some models of virtual wards involve a lot of travel. So instead of a patient coming to a hospital, we're seeing multiple clinicians visit patients throughout the day. This will significantly increase travel carbon emissions. In addition, we know that this won't be leaving hospital beds empty, so therefore we won't be seeing a quick decrease for the hospital's carbon emissions either. So it's really important that we start to evaluate care pathways, particularly new and emerging care pathways, through the triple bottom line analysis, looking at care quality, cost efficiency, and carbon reduction. This helps us to get the level of granular detail that will educate us on where we can both increase efficiencies and reduce emissions, so supporting the target to be a truly sustainable healthcare system. Sustainable healthcare, as I'm sure many of you are aware, spans every corner of the NHS that you can imagine, from operational elements such as our estates and what we buy, through to clinical and patient engagement, so transforming the way we care for people to ensure that it's as low carbon as possible. We're really heavily reliant on research and innovation, so we don't know exactly how we're going to achieve true carbon neutrality yet. It's a really new and emerging area with new inventions, innovations and solutions being created daily across the globe, which makes it an incredibly exciting place to work. I'm going to hand back over to David to go through what the virtual wards looks like in Hampshire hospitals.
Thanks, Kate. So we appreciate that on this in this conference, there's going to be lots of people from all over parts of Europe. So what are virtual wards? So virtual wards within NHS England are a very specific group of people. These are people who are acutely unwell that until recently would have had to be managed in a hospital. So this is true hospital level care at a patient's place of choice, which is often home, could be a nursing home. This care, people think instantly has to be just solely remote. Actually, that's not necessarily the case. It's a blended approach to healthcare. Some of this can be face-to-face, but the majority of this is conducted in a remote fashion. It's true hospital at home. And it breaks down into two main ways of working. Either we're going to prevent an admission to hospital, or we're going to support an early discharge from hospital, making sure that that patient can get wraparound care at home safely. Kate?
Thanks. So when looking at the carbon impacts of the virtual wards, we set some pretty clear objectives, and these have been fine-tuned somewhat since last year. So to run through them, the first objective was to establish the carbon impact of a patient journey through a virtual ward pathway by utilising existing toolkits and national carbon output measures. So essentially what happens to the patient's carbon footprint when introduced to a virtual ward. The second objective was to identify the carbon benefits of a virtual ward relative to a traditional inpatient bed day, and in addition, looking at other benefits such as avoided carbon emissions. And the third objective, which is what we've been working on essentially since last year, was to identify the methodological differences in calculating carbon emissions, either being available through a large data extraction or a manual audit. And I'll go into these in a bit more detail through the methodology. So I did go through this in quite some detail last year, but I think it's really important to go through again to set the context. So we conducted a retrospective cohort analysis where we initially mapped patients' journeys through both acute respiratory infection and frailty pathways. This was done using the SUSQI methodology from the Centre for Sustainable Healthcare. So we first conducted a detailed case review of 30 patients that were randomly selected, and you can see that in the green boxes on the right-hand side. We went through each patient record to identify the carbon activity hotspots or carbon activity points, throughout their journey from admission through to discharge. For the large-scale analysis, we pulled all the virtual wards admissions from May 2022 to May 2023. 132 patients were excluded due to data quality issues, leaving 1,260 patients in total. What we did is we used a small patient cohort to ensure that the large BI data extract was largely on the right tracks. We were able to use it as a base to make some adjustments and identify any outliers. The combination of these approaches allowed for a robust assessment of carbon emissions in the patient care and highlighted potential benefits of improved data accessibility. The phase 2 methodology is essentially comparing both approaches and seeing if there's any statistically significant difference. Our hypothesis was that there was not any significant difference in the carbon cost between the manual audit and the automated data extract. So now we're going to go into the results for both phases, and I'll hand over to Becky for the phase 1 results.
Okay, so our findings started to look at the average carbon emissions per patient per day. We looked at this with easy comparison to the toolkits. As you can see, the highest carbon factor was attributed to the high dependency units, as you would expect. We then also worked out through the toolkit that the average inpatient stay gave us a carbon emission of 37.9 a day. In the green boxes, you can now start to see what happens with the average carbon emissions when a patient is on the virtual wards. The average carbon emissions for a patient from admission to discharge equates to 24.1 kilograms of carbon per day. When we narrowed the analysis down further to just the virtual ward element only, for both sample sizes, it was only 8 kilograms of carbon per day. This is actually only 1/10 of the high dependency unit and a quarter of the emissions for an average inpatient stay. So we're actually confirming our predictions here that virtual wards is a low carbon model of care, and that being on a virtual ward really supports a lower carbon footprint. The second analysis, we wanted to look at what the actual prevented carbon emissions were. And this is a really important factor to look at when thinking about increased capacity for the trust, and adds another level of comparison between our virtual wards and the traditional inpatient stay. So using the previously created methodology that Kate has spoken through, the virtual ward team were able to calculate bed days saved. And for this cohort of patients, we calculated that over 6,000 bed days were saved for the collection period. Using this, we then had a calculation looking at the average hospital carbon cost and subtracted the average carbon cost from home. The results on the bottom right-hand circle then came back as an impressive 283,337 kilograms of carbon that was prevented. It's important to note here that this is not a reduction in carbon to the trust. These were not savings because those beds were actually still in use. What we're capturing here is actually the prevented carbon and the increased capacity. So in recognition, that's a really hard number to try and get your head around. And what does over 283,000 kilograms of carbon actually equate to? So this actually, when we put it into miles driven, equates to over 726,000 miles, which actually is just shy of driving to the moon and back. This is a really fantastic finding for Hampshire hospitals and reconfirms again the power of analysis and research, and confirming that virtual wards is a low cost and low carbon model of care.
Thanks. And our second analysis reviewed the methodological approaches, as I've mentioned before, to see if there was any significant difference in results from both the manual audit compared with the large data set. As you can see on the screen, the dark grey is the manual audit and the light grey is the large data extract. And by looking on the graph, it doesn't look as though there's that much difference between the two. Potentially for the first or last patient, there's a few differences. However, in fact, we did find there was a significant difference between both approaches. So our results indicated that the manual data set results in higher carbon costs or carbon captures. This could be due to out-of-hospital factors which are not easily obtainable through the in-hospital systems, so such as the GP call-outs or the community nurse call-outs. So it's worth noting as well that both approaches found that virtual wards was much lower in carbon than traditional inpatient bed days would have been. In terms of carbon hotspots, we've outlined 3 on the screen there. We covered these in detail in the last session, but I'll give a brief overview now. So in no particular order, ambulance journeys were found to be a carbon hotspot for this pathway. I'm sure it won't come as a surprise to you. Ambulance travel is has really high carbon emissions associated, far higher than many other forms of transportation. We found that lots of patients arrived by ambulance and then didn't go on to stay in an inpatient bed day, potentially indicating that they could have been transported via different alternative modes of transport. A&E attendance, emergency department attendance, was another hotspot, and we know that there was 45% of all patients attended the emergency department, which was quite high. These are really resource-intensive environments, and we've done some recommendations around how to avoid that where possible. Transportation of diagnostics tests was another carbon hotspot. So there was multiple journeys being made to transport diagnostics tests between hospitals. That equated to almost 20,000 kilograms of CO2e across the data collection period. We're actually working with the pathology networks to embed sustainability to help them reduce their carbon emissions, as we know this is a particular hotspot within the NHS, looking at things like travel optimization and reducing plastic use. In terms of limitations for the paper, we recognise that measuring carbon emissions and creating carbon footprints is a really highly complex process. This is hard enough for a static object, but even harder when you consider something as complex as a care pathway. Data quality was another limitation. I've mentioned already the GP and community call-outs were not always available, particularly in the larger BI data extract. But other elements such as PPE usage wasn't always captured. And the third limitation is the impact of technology is not fully recognised. So within one patient in the manual data audit, there was a mention of health monitoring apps, but we know this is much larger in reality. And more evaluation needs to be done on the impact of technology and if that has any impact on length of stay, for instance.
Thanks, Kate. So in conclusion, I think we have shown definitively that virtual wards are actually a lower carbon model of care. I think what's really important to realise is that when we start assessing our hospitals, we have developed a way that you can in broad stroke assess your carbon impact. However, at the moment, the way in which data is collected and the fact that carbon assessments is so complicated, to get the true benefit, we're still limited to manual data collection. So there are good ways that we developed, but I think in the future that can be improved upon. Also, the national toolkit, which you're all very much welcome to, has been validated by this, and I think it really helps support assessing how healthcare can impact on carbon production. So taking this further, I think we're going to keep going with the research, try and refine it, write this up in a peer-reviewed journal so that it's readily available to everyone. Regards to locally, we've already got the electric car on order, so we can transport bloods and other tests around our different sites with a minimal carbon impact. And I think part of the learning that we want to share is why we're here today, because I think it is important to understand there's new ways of giving care which doesn't have to impact on the planet as much as it has done in the past. So thank you very much for your time today. I hope you found it interesting. And on the next slide, our contact details are there. So if you want to reach out and discuss it further, we'd love to collaborate with you. Thank you very much.
Thank you.
Hampshire Hospitals, thank you. You are truly reimagining healthcare. This is a seminal example of how to integrate carbon management in healthcare to create benefits for the environment and patients. Thank you. We have now reached the Q&A portion of our session. If you have any questions for our panelists, please feel free to type them into the chat. I'll start with a question to Anna-Lisa. Welcome back to the stage. As mentioned, I'll start with a question for Anna-Lisa. What visibility do you have to the supplier's carbon footprint methodology and accuracy? This healthcare provider are dealing with a similar issue in that they are relying on suppliers to provide accurate data, and they are currently not capable of getting it.
Yeah. Excellent. I tried to answer that one in the chat, but there's a limit on the number of words. So if there's like a 3-part answer there in the chat, it's a really good question. Clearly, suppliers do struggle to get the data together with their calculation methodologies, the completeness, the accuracy. But acknowledging all of that, we didn't want perfection to be the enemy of progress. We still want them to commit, to be ambitious, to engage, to measure, to report. We're expecting them to demonstrate continual improvement year on year. We do ask them what method they used. So they pick from a drop-down list on the platform, whether they use the greenhouse gas protocol or another method. There's options available. We also ask them how confident they feel about the data that they're submitting to us, just on a high, medium, low with a pop-up box that explains that. So we can track if, for instance, confidence is increasing year on year. Remember, this project runs until 2040. So we can track if suppliers are getting more confident with what they're providing to us. We do also give them, I forgot to say in my presentation, we give them access to free tools. So one thing is the Smart Carbon Light calculator, which will do a basic carbon footprint for them very easily. Or if they've got the information, they can use just a free report only, where they copy and paste from their own annual reports into the system, or they can access, the full functionality of the platform for there's discounted rates available. So we give them all the tools, resources, we signpost them to courses, to training courses, etc. We give them everything we can, but we do acknowledge that their data may not be perfect. It's still more relevant to us. It's still better than the spend-based estimates. It's still an actual measure of real impact, and it's engagement and it's commitment for them to measure and report annually and reduce. So I do acknowledge all of those challenges, but we go into that with our eyes open, I suppose.
Thank you for that answer. It is a complicated question, but I think you provided a very well-formulated answer. Thank you. I'm going to move on to a question for Kanko. You have clearly identified a lot of the emissions from your hospital, but what categories of emissions at the Karolinska Hospital do you think there's a need for innovation or solutions, and where do you think there's a need to expand your emission calculations?
Good question. I mean, of course, there's a lot of challenges, and we only have a very limited amount of data, actually, that we can produce those reports and actually can look into. So I think we have like a list of 80 different products we have the emissions to, and a big hospital like ours definitely uses more than 80 products. So it's definitely also the thing that we've heard about now before, and it's very coupled to the question from we just had, that it's a lot from the supplier. So if we don't have the data from the supplier, then of course we can also not do our own calculations and see about our emissions. So it's definitely a lot about the procurement part, first of all, to really see, okay, if we do a new procurement with somebody, that we have that in the requirements that they have to have the emission data for their products, because I think a lot of the companies actually have the data themselves. It's just if nobody asks for it or if nobody wants it, then they will also not give it out. So that's one part. And the other part is, of course, we do need a lot of innovation projects like the ones I mentioned about the aprons and the gloves, because there is a lot of things happening. And so we also need to reach out to especially institutions and universities that have great ideas. And like the gloves, it's partly also from the Danish Technical Institute. So they developed this on a very, very small scale and then give them the possibility to try them out in a department, and then also be open for that some innovation project that sounded great might not be so good after the first trial of a week. And yeah, but then it's also, of course, this plus then also changing the ways we work. Because just because we think, oh, these reusable aprons are great, doctors and nurses also need to try them out. Like, do they work for them? Is it going to make their workday harder, or is it making them easier? Then, of course, it's not going to be a problem to include that. But yeah, it's also often a very big communication thing of communicating it in a good way and seeing that everybody is on board and decisions are made on the top and then just dumped on the bottom.
Thank you for your answer to that question. There's a lot of dimensions that we have to account for, of course, when we strive to reduce our emissions or the emissions of hospitals. Unfortunately, we are reaching the end of this session. I would like to thank the audience for your questions and the speakers for answering the questions in the chat. You're welcome to join the networking sessions this afternoon to ask the speakers questions. As we close today's session, I want to thank our esteemed speakers again for sharing their knowledge and experience on the front line of climate smart solutions. It is clear that tackling Scope 3 emissions will require continuous collaboration, data management, and innovation. Today's discussion has provided valuable insights into how the healthcare sector can lead by example. This brings the first half of the day to a close. We invite you all to have a nice break, a nice lunch, and to join us back here in 1.5 hours at 14 Central European Summer Time to kick off the afternoon session with our third session, Advancing Healthcare Climate Resilience, a Holistic Approach. As a reminder, when you rejoin, make sure to click on the afternoon block in Hublio, as the morning one is complete. I would like to thank everyone for attending and engaging in this critical conversation.